Can we start?
Yes, sir.
Today's topic is increased intracranial pressure.
Good afternoon, sir.
Good afternoon.
Am I audible, sir?
Yeah.
Yeah. So, I think, sir, already 3 or 4 residents are there, so we can start. So,
Yeah.
first of all, I want to say thank you so much for accepting this invitation. And about sir, I want to say few lines. For the good clinician, it is very important that we diagnose clinically. And for the good physician, it is very important to make the brief and small list of investigation. And for a good doctor, we have to write down a very short and sweet treatment. So all these 3 qualities are present in Dr. Jaiprakash, sir. So thank you so much, sir, again for accepting this invitation. And I think, sir, you can start now because already 4 or 5 residents are there and our faculty has also joined.
Welcome, Dr. Rekha. Thank you. Today's topic is increased intracranial pressure. Before we proceeding to increase intracranial pressure, first we discuss some physiology of the ventricles and cerebrospinal fluid. There are 4 communicating cavities inside the brain parenchyma, lined by ependyma and contains cerebrospinal fluid. This cerebrospinal fluid is secreted by choroid plexus at the rate of 20 ml per hour. Total volume of CSF is 150 ml in infants and 150 ml in adults. 75% of cerebrospinal fluid is produced by choroid plexus of ventricle, while 25% from extrachoroidal sources. CSF flow is due to pressure gradient. There is 180 millimeter of water of pressure in intraventricular system, while the 80 millimeter of water at superior sagittal sinus. Due to this pressure gradient, CSF flow from ventricles toward the superior sagittal sinuses. All the ventricles communicate with subarachnoid space. There are 3 foramina in the fourth ventricles. First, the CSF is produced in lateral ventricle and circulate through foramen of Monro, and CSF drains into the third ventricle. From third ventricle by aqueduct of Sylvius, that is 3 mm long and 2 mm wide in diameter. CSF flow toward the fourth ventricle by this aqueduct of Sylvius. From fourth ventricles, the CSF flow to lateral foramen of Lasca and midline foramen majendis into the basal cistern, and from basal cistern to the cistern system, CSF flow toward the convexity of brain and absorbed by arachnoid villi in the subarachnoid spaces and in all the sinuses. This diagram shows how CSF flow from third ventricle to lateral ventricle to third ventricle, and then aqueduct Sylvius to the fourth ventricle and toward the all systems. Cerebrospinal fluid is clear, colorless fluid that is found in subarachnoid spaces and ventricles. The function of cerebrospinal fluids are to support and cushion the CNS against concussive injuries, transport hormones and hormone releasing factors, remove metabolic waste product through absorption, mainly through arachnoid villi. CSF pressure is 80 to 180 millimeter of water. CSF is sterile. pH is slight acidic due to carbon dioxide is slightly more in CSF. The specific gravity of CSF is 1.007. Glucose is the 2/3 of the plasma glucose, that is 66%. Total protein 15 to 45 milligram per deciliter in lumbar system. This slide shows the upper limit of CSF parameter by age group. The WBCs are 5 to 15 is normal in age group of less than 1 month, while in above age 1 month, the any WBC more than 5 is abnormal, and any polymorphonuclear cell present, that is the abnormal. Protein may be up to 150 in infants premature and less than 1 month of age. After that, normal CSF protein is up to 45. Glucose is the 2/3 of the blood glucose level. Raised intracranial pressure. CSF pressure's normal range in newborn is 5 mm of mercury. In infants, 6 to 15 mm of mercury. In older children, 10 to 15 mm of mercury. When the pressure is above 20 mm of water, we call that child have raised intracranial pressure. And if pressure is more than 30 mm above, then cerebral perfusion compromised. Intracranial pressure is severely raised when pressure is above 40 mm of water. Normal cerebral perfusion pressure lies between 60 to 80 mm of mercury is the net pressure gradient for delivery of oxygen and glucose to the cerebral tissue, that is to the brain. Cerebral perfusion is equal to mean arterial pressure minus intracranial pressure. If there is increased intracranial pressure, cerebral perfusion is decreased. Normal range of mean arterial pressure is 70 to 100 mm of mercury. Intracranial dynamics describe the interaction of the contents of the brain cranial cavity, that is the brain parenchyma, blood, and CSF. Brain is the 85% of the contents of the intracranial cavity, blood and CSF 15%. If intracranial pressure increase, then there is decreased perfusional pressure that leads to the ischemic necrosis of the brain tissue. Factor affecting cerebral blood flow. There is the auto-regulation of the cerebral blood flow. Cerebral blood flow maintained in spite of change in blood pressure. Acid-base balance of CSF is also regulate the cerebral blood flow. CO2 is the vasodilator. And body-brain temperature also regulate the cerebral blood flow. When there is fever, the blood flow toward brain is increased. Hypo and hyperglycemia is also affect the cerebral blood flow. Hypoxemia in prolonged seizure, HI, also affect cerebral blood flow. Vasoactive mediators, inflammatory cytokines, that also leads to increased cerebral blood flow. Then change in osmolality, electrolytes leads to increased cerebral blood flow or decreased cerebral blood flow. Cerebral edema, abnormal accumulation of fluid within brain parenchyma, is life-threatening. This slide shows the pathophysiology of raised intracranial pressure. When there is insult to the brain, there is tissue edema. Then tissue edema leads to increased intracranial pressure, and increased intracranial pressure leads to the compression of the ventricles and compression of the blood vessels. And compression of blood vessels lead to the decreased cerebral blood flow, and decreased oxygen supply and nutrient to the brain cells lead to the death of the brain cell. And edema around necrotic tissue, increased intracranial pressure with compression of the brain stem and respiratory center leads to abnormality of the vitals, and there is accumulation of carbon dioxide and vasodilatation leading to increased intracranial pressure due to increased blood flow and vicious cycles insult. Causes of increased intracranial pressures are hydrocephalus, trauma, CNS infection, it may be meningitis, tubercular meningitis, viral infection, etc. Intracranial hypertension, intracranial bleeding, intracranial space occupying lesions, tumor, abscess, granulomas, metabolic causes like Ray's syndrome, inborn metabolism, acute liver failure, arterial venous strokes, infarcts, hypertensive encephalopathies, and raised ICP may be idiopathic or it may be due to drugs. There are 5 types of the cerebral edema. The cytotoxic cerebral edema results due to cell death. There is permeability of cell is normal. There is disturbances in ionic homeostasis, leads to cellular swelling and cell necrosis. Both gray matter and white matter are affected due to cytotoxic cerebral edema. While in vasogenic cerebral edema, there is cytokine-induced increased capillary permeability that leads to the breakdown of the tight endothelial junction in capillaries, and there is cell swelling, and it may be due to trauma, tumor. Mainly vasogenic cerebral edema affect white matter. Interstitial cerebral edema results of increased hydrostatic pressure, and due to hydrocephalus, there is surrounding tissue is edematous. When there is osmolality change, there is osmotic cerebral edema due to decreased osmolality, hyponatremia, and syndrome of inappropriate antidiuretic hormone. There is the water content increase, and that leads to the swelling of the cells. When there is hypertension, then there is hydrostatic pressure increase, and that leads to the hydrostatic cerebral edema. This slide shows the classification of the cerebral edema. There are the 5 types as mentioned in previous slide. The pathophysiology in cytotoxic is cellular, metabolism, sodium potassium pump. In vasogenic, blood-brain barrier is breakdowns. In interstitial, CSF leaks. In osmotic, there is increased osmotic gradient, and in hydrostatic, there is increased hydrostatic gradient. The pathology in cytotoxic edema is a cell swelling. In vasogenic edema, increased capillary permeability. In interstitial, there is the hydrocephalus. In osmotic, there is increased blood osmolarity, and in hydrostatic, there is the hypertension. Its underlying pathology. The content in cytotoxic is the water, sodium, no protein. In vasogenic edema, there is plasma and high protein due to vascular leakage. In interstitial, there is the CSF leakage in the surrounding tissue and having low protein. In osmotic edema, there is water and no protein. In hydrostatic, there is also water and sodium. There is no increase in protein. Location cytotoxic edema affect both gray and white matter. Vasogenic edema mainly affect white matter, while the interstitial edema affect periventricular white matter due to CSF leakage. In osmotic cerebral edema, white matter affected, and in hydrostatic, mainly white matter affected. Extracellular fluid in cytotoxic edema decrease, while in others increase. Blood-brain barrier in cytotoxic edema is intact, while in vasogenic edema it is disturbed, and in rest type of edema that is intact. Steroids have no effect in cytotoxic edema, but steroid is effective in vasogenic edema and having no effect on other types of the cerebral edema. Diuretics having transient effect in cytotoxic edema and minimal in vasogenic effect, while in interstitial and hydrostatic have transient effect. The clinical presentation of increased intracranial pressure in neonate and infants, there is bulging fontanelle, cranial suture widened and separated, increased head circumference. Baby may have high pitched cry, seizure, vomiting, not gaining weight. In older children, there is headache, vomiting, diplopia, vision loss, photophobia, change in level of consciousness, change in size and reactivity of the pupil. There may be sunset sign, impaired eye movement, decreased sensory and motor function, and there is Meesmann sign and papilledema. There may be change in vital signs. There may be increased blood pressure, decreased pulse, that is bradycardia, change in respiratory pattern. There may be Chinese stroke or various pattern of respiratory. Decortical or decerebrate posture. There is long tract sign. There may be Babinski positive or tone may be altered, and there are various types of herniation syndrome. And clinical signs appear at the when there is intracranial pressure is more than 30 millimeter of mercury. This slide shows the various types of the herniation syndrome. Increased intracranial pressure leads to decreased cerebral perfusion and there is brain ischemia. Further increase in intracranial pressure leads to cerebral herniation. There are 4 types of herniation syndrome: cingulate herniation, uncal herniation, or central herniation, or upward cerebral herniation, or cerebellar tonsillar herniation. Management of increased intracranial pressure. Investigation is required as per history. If there is history of trauma, then there is urgent non-contrast CT scan, or if there is chances of infection, then CBC, ESR, MT, blood culture, CSF culture, urine culture, or X-ray, MT, Montauk test if tuberculosis is suspect, sputum, or MRI brain, fundoscopy, of EEG, intracranial pressure monitoring, or vital monitoring. All these are the required when there is increased intracranial pressure. Intracranial pressure should be maintained below 20 millimeter of mercury. Age-specific cerebral perfusion pressure targets are there as described by various institutes. In children in between 2 to 6 years, the target of cerebral perfusion pressure is 50 millimeter of mercury. In between 7 to 10 years, 55 millimeter of mercury. In between 11 to 16 years, 65 millimeter of mercury. Managements are the first tier therapy. First, there is elevation of the head of bed 30 to 45 degrees. With head should be midline and neck should be minimally handled. There is ventilation and oxygenation, PaCO2, PaO2 to be managed 100, around 100, and PaCO2 to be more than 30. ET intubation is required if there is Glasgow Coma scale is less than 8, analgesia, sedation, and all these are the required. If we use neuromuscular blockage, then continuous EEG monitoring is required to rule out status epilepticus, because when there is neuromuscular blockage, the clinical seizure will not be seen. There is the monitoring of the intracranial pressure, the transducer either placed in the intraventricular cavity or brain parenchyma. There is maintenance of the normal blood pressure, hypo and hypertension both should be avoided. Maintenance of the normal acid-base balance, maintenance of the normoglycemia, euglycemia, hyper or hypoglycemia both are detrimental. Seizure prophylaxis, fever control, or nutritional support. Then there is, we can use hypertonic saline, that is the 3% saline. Dose is 0.1 to 1 ml per kg per hour, continuous infusion. And hypertonic saline is preferred over the mannitol. Second line mannitol 0.25 to 1 gram per kilogram IV over 20 minutes or 6 hourly. Avoid osmolarity more than 320 milliosmol per liter. If there is hyperosmolar, then there may be cell shrinkage. Corticosteroid dexamethasone 0.15 milligram per kilogram per dose 6 hourly in vasogenic edema, decrease capillary permeability and reduce inflammation and exudate formation. Corticosteroid is usually used in children for pyomeningitis and tubercular meningitis. Second tier therapy is the surgical decompressive cranectomy or continuous phenobarbital infusion or hyperventilation if there is acute increase in intracranial pressure. This slide shows the diagram of the therapy of the increased intracranial pressure. Intubation is required. Cervical spine precautions should be properly handled. Resuscitation, trauma survey, hemodynamic stabilization, cranial CT if there is a patient of trauma. First type therapy is intubation and controlled mechanical ventilation, head of bed elevation, sedation, analgesia, neuromuscular blockage, CSF drainage, osmolar agent, hypertonic saline mannitol. Consider continuous EEG monitoring. Only feasible if a ventriculotomy catheter is used rather than a parenchymal transducer. Consider repeat CT scan and ensure extracerebral stability, rule out unrecognized seizure. Emergency surgery is required if there is large hematoma leads to the chances of the herniation. Placement of ICP monitor, consider placement of brain tissue oxygen monitor. Emergency treatment for signs of the cerebral herniation, if there is cerebral herniation. Second type therapy is barbiturate infusion, decompressive craniotomy, mild hypothermia, hyperventilation, lumbar CSF drainage. Thank you. Any question?
Yes, sir. I have one.
Thank you so much, sir, for such a wonderful lecture. And I request all the residents, if you are having any query, you can ask.
Hello, sir. Can you audible my voice?
Hello.
Hello. Can you audible my voice, sir?
Yeah.
Sir, I have one question. अगर रेज्ड आईसीटी का कोई पेशेंट आता है मेरे पास, तो उसमें मेरे पास दो ऑप्शन है, अगर मैनिटोल देना है या 3% NaCl देना है, तो फर्स्ट कौन सा प्रीफर करें?
3% नॉर्मल है, 3% NaCl.
अच्छा, और सोडियम हाइड्रोक्साइड है तो मैनिटोल कर सकते हैं, ऐसा कुछ ऐसा है?
क्या चीज है?
वो अगर सोडियम हाइड्रोक्साइड है मोर देन,
हाँ, सोडियम अगर हायर साइड है तो आप मैनिटोल यूज कर सकते हैं, पर आपको ऑस्मोलेटी का ध्यान रखना है कि वो मोर देन 320 नहीं होना चाहिए. और अगर सोडियम हायर साइड में है तो आपको 5% डेक्सट्रोज प्लस हाफ NS यूज करना पड़ता है, प्लस कैसियल इंक्लूड करना. आपको हाइपरनेट्रीमिया का मैनेजमेंट है ना, उसमें आपने नेल्सन की टेबल में दिया हुआ है मैनेजमेंट में कैसे यूज करना है. उसके अंदर 5% ग्लूकोज प्लस हाफ GNS प्लस 20 मिलीमोल के अकॉर्डिंग अपने को पोटेशियम यूज करना पड़ता है. उसके अकॉर्डिंग बाद में अगर आपको लगता है कि सोडियम कम हो रहा है या नहीं हो रहा है, उसके अकॉर्डिंग देखना है. अगर सोडियम कम नहीं हो रहा है तो आपको फ्लूइड बढ़ाना भी पड़ सकता है. जो डेली मेंटेनेंस होता है उसका 1.25% तक दे सकते हैं अपन.
ओके सर. और सर मुझे और एक क्वेश्चन है, अगर मैनिटोल हमने स्टार्ट किया, ठीक है, 6 वाली, तो मैक्सिमम कितने दिन तक दे सकते हैं, क्या
3 days, 2 to 3 days जी.
Okay, sir. Thank you, sir.
Right.
Any other resident is having any query? I think no one is having any query. So I think we can end right now. So again, thank you so much, sir, for accepting our invitation, and it's really our privilege that we are having such a great speaker who has delivered such a wonderful lecture in last 1 hour. So, boss, you want to say anything related to this topic? Any key points you want to summarize?
की पॉइंट यही है कि आपको कॉज पता होना चाहिए. कॉज क्या है, कोई एक्यूट कॉज है या क्रोनिक कॉज है. मान लो आपको ये लग रहा है भाई अगर इंट्राकैंडियल प्रेशर है वो क्यों है, मान प्रीमेच्योर है, प्रीमेच्योरिटी में अपने पता होता है कि इधर हेमरेज होने की पॉसिबिलिटी है या कोई कॉन्जेनिटल इन्फेक्शन हो सकता है. आपका एटियोलॉजी इंपॉर्टेंट है. एटियोलॉजी अगर आपको पता लगेगा तो ट्रीटमेंट आपको उसके अकॉर्डिंग ही देना पड़ेगा. मान लो प्रीमेच्योर है, उसका आपका थ्रोम्बोसाइटोपिनिया आ रहा है, बिलिरुबिन बढ़ा हुआ है, SGOT-GPTB बढ़ा हुआ है, आपने टॉर्च प्रोफाइल कराया, CMV आ गया, तो आप गेनसाइक्लोविर देंगे तो वो ट्रीटमेंट तो उसी से होगा. तो एटियोलॉजी बहुत इंपॉर्टेंट है किसी भी चीज के लिए पता करने के लिए, उसकी एटियोलॉजी क्या है.
डेफिनेटली. बस ऑल्सो आई हैव वन क्वेरी कि कई बार ऐसा होता है कि पेशेंट एडमिट है, वेंटी पे है और रेज्ड आईसीटी के सारे साइंस हैं और हमने मैनिटोल दिया, जैसे आइडियली आफ्टर 3 days वी हैव टू शिफ्ट आइदर ऑन द ओरल ड्रग्स और वी हैव टू स्टॉप. क्योंकि 3 डेज के बियॉन्ड देना पॉसिबल नहीं है, पर जैसे ही ओरल पे शिफ्ट करते हैं अगेन पेशेंट इज हैविंग रेज आईसीटी साइन और पेशेंट का कंडीशन और डिटोरेट होने लगता है, तो कई बार हमें मेनिटोल कंटिन्यू भी रखना पड़ रहा है। तो मैक्सिमम कितने दिन दे सकते हैं?
3-4 डेज के बियॉन्ड नहीं दे सकते, क्योंकि इसका फिर इफेक्ट खत्म हो जाता है। फिर अपने को देना होता है मैनिटोल के साथ ग्लिसरॉल आता है, केमिटोल, दोनों कंबाइंड आता है। उस समय के लिए वो भी दे सकते हैं। पर अगर आपका रेज आईसीटी है, कंट्रोल ही नहीं हो रहा है, तो आपको हाइपर वेंटिलेट भी करना पड़ सकता है, हाइपरटोनिक सलाइन भी देना पड़ सकता है। और अगर आपका इलेक्ट्रोलाइट ठीक है तो कई बार अपने को फ्रूसामाइड भी टेम्परेरी देना पड़ता है, डायूरेटिक्स भी यूज करने पड़ते हैं। तो अदर ऑप्शन है, उन पे भी देखना है क्या है क्या नहीं है। और दूसरा है कि अगर आपका ठीक नहीं हो रहा तो आपने मान के चलो भी इंट्राक्रैनियल पैथोलॉजी है वो वर्सन हो रही है, तो अपने को रिपीट सीटी स्कैन या रिपीट एमआरआई करा के भी देखना पड़ता है कि पहले से कुछ चेंज हो रहा है क्या। अगर मान लो हाइड्रोकिफलस है जैसे, और उसका अगर अपना आपने देखा कि भाई उसका ब्रेन पेरेनकाइम है ओनली 1 सेंटीमीटर का ही रह गया है, तो आपको सट सर्जरी भी करानी पड़ सकती है, सर्जरी ओपिनियन लेना पड़ सकता है। तो कंटिन्यू जो हम पेशेंट को मॉनिटर करते हैं वही इम्पोर्टेंट होता है, कि उसी से ही पता लगता है भाई क्या हो रहा है, क्यों हो रहा है।
ओके, मतलब बियॉन्ड 3 days वी शुड नॉट कंटिन्यू द मैनिटोल आइडियली।
आइडियली ये है कि आपको मैनिटोल 1 दिन 2 दिन और दे सकते हैं, लेकिन आपको कॉज पता करना पड़ेगा कि ऐसा क्यों हो रहा है। बच्चे
कई
को
बार
अभी तक
वायरल एनकेफेलाइटिस लेबल करने के बाद, क्योंकि पेशेंट एकदम सडन 1 और 2 डेज की हिस्ट्री के साथ अनकॉन्शियस और प्रीवियसली 1 day फीवर था और कन्वर्जन आया और अनकॉन्शियस होकर के पेशेंट आए और पेशेंट वी केप्ट ऑन वेंटिलेटर, और हम जो
इम्पोर्टेंट चीज
स्टार्ट
ये
कर
है
रहे मेडिसिन।
कि बहुत सारे जो वायरल एनकेफेलाइटिस के बच्चे होते हैं वो अपने यहाँ पीसीआर होता नहीं है। दूसरा चीज होता है उनमें से कई ऐसे भी होते हैं जो ऑटोइम्यून इनकेफेलाइटिस के भी होते हैं, जिसमें लंबा समय लगता है। ऑटोइम्यून इनकेफेलाइटिस भी बहुत
हाँ हाँ
कॉमन
हाँ,
होती है। और वायरल
यस।
जो एजेंट्स होते हैं वो मिमिक्री करते हैं, तो वो अपने को वो वैसे ही आते हैं। अपने को उस टाइम कई बार मेथाइलप्रेडनिसोलोन है वो भी यूज कर सकते हैं। तो लोडिंग
ओके
डोज अपन 30 मिलीग्राम पर किलोग्राम से देते हैं ओवर 3 डेज के लिए, तो उससे भी बहुत
ओके
अच्छा रेस्पॉन्स आता है।
ओके।
ये मान के चलते हुए भी ऑटो इम्यून इनकेफ्लाइटिस हो सकता है।
डेफिनेटली। और कई बार बॉस ये भी देखा गया है कि हमने जैसे पेशेंट को स्टेरॉइड दिया जिसमें इसी तरीके का
हाँ
डाउटफुल डायग्नोसिस है, डेक्सोना या
हाँ
मिथाइलप्रेट
हाँ
दिया, तो विद इन 1 और
हाँ
2 days और पेशेंट की कंडीशन बिल्कुल डिटोरेट होकर के पेशेंट एक्सपायर हो गया। तो क्लिनिकली
उसमें
कोई क्लू है जिससे हम ऑटो इम्यून और वायरल एनकेफेलाइटिस को डिफरेंशिएट कर सकें? कोई क्लिनिकल क्लू?
क्लिनिकली ये है कि अगर, हेलो,
जी बोस, जी बोस।
हाँ, अगर बेसल मेनिंजाइटिस आ रहा है, टेम्पोरल और लोब इन्वॉल्वमेंट है, तो कई बार उसमें पॉसिबिलिटी रहती है इसकी। वायरल वायरल एनकेफेलाइटिस के साथ ऑटो इम्यून की रहती है प्रोबेबिलिटी।
ओके, मतलब वो ये कि फर्स्ट प्रायोरिटी
हाँ,
ये है
और
कि
एक्स्ट्रा
इमेजिंग
पिरामिडल,
होकर के थोड़ा डायग्नोसिस कंफर्म्ड हो,
हाँ, एक्स्ट्रा
देन।
पिरामिडल सिम्टम्स होते हैं वो मेनली इसमें ऑटोइम्यून एनकेफेलाइटिस में होते हैं। अगर एक्स्ट्रा पिरामिडल सिम्टम्स भी आ रहे हैं साथ,
ओके,
ऐसे लिए।
so any other resident is having any query about this topic? No? So I think was nice discussion already done. So thank you again, boss.
वेलकम।
Uh,
तो स्लाइड
I think
प्रेजेंटेशन शेयर करना है।
हाँ बोस, प्लीज आप ना मुझे शेयर करना, फिर मैं रेजिडेंट के साथ शेयर कर देती हूँ, ये
ठीक ठीक।
उनके लिए भी फ्रूटफुल रहेगा।
ओके ओके,
Thank you so much, boss.
वेलकम।
Thank you again for accepting invitation. Now we can stop, I think.
ओके।